That's a given 2 minutes.
Mhm.
We are live. We are live. And this is Senate Finance. This is March 31st. And we are going to do our first walkthrough. We did a couple last Friday. We're trying to walk through all our House bills. To date, this is probably the biggest one we've gotten. The yield bill, which also has a lot of tax stuff on it, education tax. Went to education. They're gonna go through their sections as quickly as possible and get it over to us. We'll start. Those are probably the two largest bills. And probably the most complicated ones we're gonna deal with. So my goal is to clear out as many of these simple little bills that have fees on them only, so that we can really sit down and have more time than we had last year to work on ed financing. So we're going to start with Jen, and Jen, you want to walk us through it? Okay.
Good afternoon, Jen Carty from the Office of Legislative Control. I'm going to put the poll up on the screen. Right. We are looking at H585, an act relating to health insurance reforms. It starts out with sections dealing with health insurer governance and executive compensation, and we're looking specifically at nonprofit hospital service corporations, which is a particular type of insurance company. In this case, we're really talking in Vermont about Blue Cross Blue Shield of Vermont. So that is who we have in the state for a nonprofit hospital service corporation. That's how they're organized.
Otherwise known as an insurance company.
Well, we have other
But it's a
insurance
different,
companies.
yeah.
We've got Cigna, which is
Right.
different. We've got MVP,
Right.
which is different. So this is specifically the framework under which Blue Cross Blue Shield, I think, is a nonprofit medical service and nonprofit hospital service corporation. This is the chapter on nonprofit hospital service.
But they are not a hospital.
No, it's a hospital service.
Service. Okay.
So there is an existing chapter in Title 8, Chapter 123 on nonprofit hospital service corporations. It has certain powers and description, and under existing law, it must be maintained and operated solely for the benefit of its subscribers. This would update some of the language and add, and shall ensure that benefits and services are balanced with the efficient and economical management of the corporation. And you'll see that ties in with some additional language in here. In existing law, there's language around the permit to engage in business and some of what the board of directors has to involve. This language isn't being repealed like it's coming out of the law. It's just being repealed from this place and added into a new section 4513A on the board of directors. And so it starts out with definitions. Provider is anyone who's a provider of hospital or medical services, or employed, who's an employee, director, trustee, or representative of such a provider. Representative of the public, which is a new term being added here in this bill, is any member of the board of directors appointed by the governor, and you'll see some more language on this coming up. And a representative of the public may be a member of the public, a subscriber, or a provider. So then this is the rest of the language that was moved from that existing section of law, saying that at least 3/4 of the board must be composed of subscribers and members of the public, and the remainder may be providers. The subscriber members have to comprise at least a majority of the board, and the corporation must provide for the election of its board at a publicly announced meeting.
Okay, so
Some of this is just reorganization.
yeah, but presently, does the governor?
No, so this is
No.
where we're getting into the representatives of the public. This is
All right.
new. Right. Most
And
of the rest is just.
subscribers
Subscriber is just somebody who is a member of the plan, who's insured. by-
Okay, so it's any member of the public that has Blue Cross insurance.
Would be a subscriber,
Would
and
be
then
a
there's also just
subscriber.
members of the public,
And
which is,
3/4 of the board.
yes, so that's moved from current law, but the same as current law, at least 3/4 of the board.
Really?
Yes, at least 3/4 of the board of directors of a corporation with structure language as subscribers and members of the public. Yes, all of this language is repeated in 4513A. the new section.
Okay,
But the new piece is the representatives of the public. And so that provision requires that 2 voting members of the board, but in no event less than 1/6 of the board of directors, must be representatives of the public appointed by the governor. And unless otherwise specified, a representative of the public has the same rights and responsibilities as anyone else on the board.
how many people on the board?
I believe there's 12. Well, yes.
12.
Yes, and you're gonna hear from DFR, I think at
Okay,
2:15, so they can tell you a lot of the why this language. Most of this language, most or all in this section came from DFR.
okay.
Um,
It's not the governor's idea,
well, DFR is
or for the governor.
for the governor, so I will let them tell you whose specific idea.
All right,
So the initial term, we're having staggered terms to begin with. So the initial term of one representative of the public is 2 years and the other is 3 years. If there are more than 2 representatives of the public, then their initial terms would be divided between those 2 initial term lengths. And then after that, each representative of the public appointed by the governor would serve a 3-year term and serve until a successor is appointed. Representative of the public can be terminated only by the appointing authority, which is the governor, by conclusion of the appointed term or by voluntarily resigning. If there's a vacancy before the end of the 3-year term, for any of those reasons, the governor will appoint a new representative of the public to complete the term. Then there's committees, requires the board or allows the board of directors to create, but one is going to be required. 1 or more committees and appoint members of the board, including the representatives of the public, to serve on the committees. It directs that the board shall create a compensation committee to review and recommend to the full board for approval all compensation packages offered to the corporation's officers and executives. And then it talks a little bit about the compensation committee would have 2 or more members who serve at the pleasure of the board, but at least 2 representatives of the public must be voting members of the compensation committee. There's some guiding principles for the representatives of the public in discharging the duties of a director, including as part of a committee. Each representative of the public shall, in determining what they reasonably believe to be in the best interests of the Hospital Service Corporation, consider the effects of any action or inaction on the subscribers, on the community and society and societal concerns of the state of Vermont, including the principles for healthcare reform expressed in HCBSA section 9371, sometimes called the Act 48 principles, and the goal that the corporation's benefits and services should be provided at minimum cost and under efficient and economical management of the corporation. They may consider any other relevant factors and the interests of any other group that the representative of the public determines appropriate to consider, and they shall not be required to give priority to the interests of any person, particular person or group described in subdivision 1 or 2 over the interests of anyone else. And then it specifies that the consideration of the interests and factors in the manner described in that subsection shall not constitute a violation of the nonprofit corporation statutes. That's what's in Title 11B. There's limitations on the representative of the public's liability. They're not liable for the failure of the corporation to create general or specific impacts on the community or on the healthcare system. They're not liable to the corporation for any action or failure to take action in their representative's official capacity if they perform the duties of the office in compliance with the nonprofit corporation statutes and this section. And in the event of a conflict that this chapter would control.
Is anybody else liable on the board?
Yes and no, I think. I think it would depend on the issue.
I was wondering why we give immunity to some and not all,
yes,
which means if you're immune from consequences, that might impact your decision.
right, they're immune for certain, from liability for certain, outcomes. So, and I would defer to DFR to talk about general liability for members of corporation boards under their purview. And then there's the representative of the public has no duty to any person who is a beneficiary of the general or specific public benefit purposes of a hospital service corporation arising solely from that person's status as a beneficiary of the general or specific public benefit. And it requires that any new hospital benefit corporation adopt bylaws in accordance with these provisions and Chapter 11B and file with the Commissioner of DFR for review and approval. And you'll see in the next full section of the bill, Section 2 of the bill directs existing hospital benefit corporations to amend their bylaws to come into compliance. The next section in this same chapter is on executive compensation. Starts out with definitions. Compensation is total cash compensation, including base salary and annual incentive compensation. And executives are the president, chief executive officer, chief medical officer, chief administrative officer, chief fiscal officer, vice presidents, and anyone in a functionally equivalent role in a hospital service corporation. Bill requires on or before July 1st of this year and prior to approving any changes to executive compensation after that date, each hospital service corporation file with the Commissioner of DFR a statement sworn by the chair of the board of directors and the president of the corporation that includes the following information about compensation paid to the corporation's executives. First, all compensation benchmarks used in connection with establishing or awarding compensation for the executives, including information used by a consultant, vendor, or other third party, a detailed compensation survey or peer group data used by the corporation or any third party retained by the corporation to establish the compensation benchmarks or otherwise establish or award compensation for each of the executives. And if there was any bonus or variable compensation paid or awarded for the prior fiscal year, what criteria were used to evaluate whether that compensation should be paid and the specific results supporting the payment. All of the information provided must be sufficiently detailed to allow for a comprehensive examination of the benchmarks and to allow DFR to perform independent computations to evaluate the benchmarks provided. It allows the commissioner to require the corporation to modify a group, so one of these peer groups of data, if in the commissioner's discretion, the group contains entities that are not sufficiently similar to the corporation in terms of size, business operations, nonprofit status, or other factors. It allows DFR to retain at the corporation's expense outside consultants and other experts that are reasonably necessary to assist the commissioner in evaluating the materials provided. And with other commissioners, control and direction acting in a purely advisory capacity. And says nothing in this section should be construed to preclude a corporation from segregating and designating anything provided to the commissioner as confidential because it is proprietary, privileged, or otherwise confidential under Vermont law. And the commissioner must maintain the confidentiality as appropriate under the Public Records Act. So that's the executive compensation piece. We have governance and executive compensation. Section 2, as I mentioned, directs each existing hospital service corporation by September 1st of this year to amend its bylaws to comply with the amendments to that chapter that were in Section 1 and file them with DFR for review and approval. Now we're changing topics, looking at expanding access to association health plans. And so this language in sections 3 and 4 would expand access to association health plans.
We reach capacity. So if I have people that aren't witnesses, can I ask you to give your seats? I've got a couple of witnesses and then you can filter back in.
We're on YouTube though, so you can.
Yeah, you can watch it on YouTube.
Would that be better?
I don't. All right. And you can watch this on YouTube 24/7.
At whatever speed you want to listen.
Groundhog Day.
I'm a fast talker though, so probably you think I can be happy. All right, so this expands the potential scope of association health plans that could be offered in this state. You'll see a caveat coming up that for current federal law, this expanded scope is not permitted, but was under the first Trump administration and may be again in the future. So it strikes a lot of the kind of commonality of interest requirements and other provisions in existing Vermont law that had narrowed the scope of allowable association health
Okay,
plans.
all right.
So
I
that's,
don't know if they come back, we may need to remove all those strikeout lines.
so the strikeout does the expansion,
Okay.
and it does the expansion starting in 2028. And then section 5 says, on or before next January, DFR must come back to committees of jurisdiction, including this committee, with certain information related to expanding access to association health plans beginning on January 1st, 2028, which would be permitted under those changes in sections 3 and 4. So DFR would come back and report the status of federal law regarding association health plans, including the extent to which federal law would allow for the expanded access to the association health plans in Vermont beginning January 1st, 2028. An analysis of the projected impacts on Vermont's health insurance markets of that expanded access to association health plans, including likely effects on enrollment in and premiums for qualified health benefit plans in the individual and small group markets, using scenarios showing potential impacts over consecutive years if various percentages of healthier lives migrate from the individual and small group markets into the association health plans. And in consultation with the Green Mountain Care Board, the potential impact of the expanded access to association health plans on the board's health insurance rate review responsibilities. So setting up a future expanded access and having a report back in the meantime, so that you can understand the possibilities and the potential impacts. Now we change topics again. So I have these reader assistance headings here. This is defining high dollar claims for claims edit purposes. This is a pretty narrow change. This relates to some language that was passed 2 years ago, I think, around claims edits and what kinds of edits insurers can make to claims. And there is language in that, for the most part, prohibiting prepayment coding validation edit review, but saying that it can be used under certain circumstances, including, and under current law, it says, including evaluating high dollar claims. This would define high dollar claims. So including evaluating claims exceeding $25,000 per episode of care. All right. Now we've got some language on site neutral billing. And really site neutral reimbursement is what we're looking at. And this would be on site neutral reimbursement for physical therapy, occupational therapy, and athletic training. So to add a new provision in Title 18, requiring health plans to establish and pay for all physical therapy, occupational therapy, and athletic training items and services provided to insureds in reimbursement amounts that are uniform and consistent across all of the plans, contracts, and fee schedules, really all outpatient. So a plan may reimburse different amounts for items and services delivered in an inpatient setting. The outpatient fee schedule has its own kind of definition, so we're describing rather than using that term. And it requires health plans to express each reimbursement amount as a percentage of the Medicare rate for the same item or service. So with an eye toward reference-based pricing and understanding what Medicare is.
Medicare paid for athletic training?
Medicare. I think services. Well, I think certain services provided by an athletic trainer, depending on the context.
Okay, maybe if it comes under the context of physical therapy.
Right. I think, I think the
Medicare.
Well, it's talking
No,
about a percentage of the Medicare rate for the same item or service. So we're looking at services provided, physical therapy services, occupational therapy services, and athletic training items or services. So items or services that fall within the scope of those professions to the extent that they are reimbursed by the private health insurers, would be A, the same reimbursement amount across all plans, and of that payer, and B, based on a percentage of the Medicare rate for the item or service. So if there's not a Medicare rate, I suppose they may not be able to do that, but I think it's more about the services that may be provided by different types of providers.
Good question.
Jen, do you mind if I ask you?
No,
So my understanding of athletic trainers is that they usually work for like a school or a university or some organization, and are they billed for the what they're providing to an individual, or?
they are sometimes. We do have a insurance mandate in Title VIII requiring health insurance coverage for services provided by athletic trainers. So I'm not sure what the context would be where insurance would be paying versus it being included in the school budget. But there may be witnesses who could speak to that more directly.
Thank you.
Does the doctor need to prescribe a certain amount of physical therapy, or once it's approved, is it really up to the patient to say, I want to go once a week, twice a week? Like, how much does this open who should determine it as to how much this is used?
So I don't believe this provision changes anything about the duration of the service or the intensity of the service. It's paying for the same reimbursement amount across all plans. So there's not different rates for independent providers, hospital-based providers, different parts of the
And I
state.
know with physical therapists, that has been an ongoing.
Right,
complaint,
this started
that
out
they
as
paid a much
just
lower
physical
rate.
rates.
If you go to my local gym and get the same trained physical therapist at the rehabilitation gym as you get if you go down to the hospital rehab. And I'm not sure if that includes the $200 facility fee or the base rate, but we can check that. But they hadn't had, we got them a raise, I think 2 or 3 years ago. They hadn't had a raise in 10 years. So I don't know about athletic trainers, news.
So my understanding, you'll want to hear from the insurers, but my
Yes.
understanding is that the suite of services provided by physical therapists, occupational therapists, and athletic trainers are largely the same sort of group of services. They may be provided in different settings by different, or for different purposes by different providers.
Right,
But
but-
that's why these are all, it started out with just physical therapy and it became apparent that it would be,
Occupational physical is meant to bring you back to full health.
right.
To me, athletic training
I think that's
is usually done to somebody that's in full health and trying.
I think it's more the healthcare side of it.
Okay,
So
we
restoring somebody's
definitely, I'm sure they're already
Physical.
emailing. We will hear from them.
Alright. There's some legacy underlining that shouldn't be in here. Section 8 is site neutral reimbursement for these services and an implementation report. And this would require that by March 1st of 2027, each insurer that is required to make these site neutral reimbursements would provide an update to the committees of jurisdiction, again, including this committee, on its implementation of the site neutral reimbursements, any trends or other financial impacts it has identified so far as a result of implementation, and any recommendations regarding enactment of additional site neutral reimbursement requirements. Section 9 is on increasing flexibility in health insurance plan design. And this is looking at, for those of you who have been on this committee for a while, you may remember that there is an maximum out-of-pocket limit for prescription drugs that is in Vermont law. That is not a federal requirement, but is a Vermont statutory requirement now in EPSA 4892 that limits the amount of out-of-pocket exposure a person with insurance has. And it's tied to the premium for the lowest cost plan that qualifies as a high deductible plan under federal law. It's really a way to sort of have an index that goes up on its own. But that has limited the ability to have some flexibility in insurance plan design, particularly in the individual and small group markets where they have to hit certain actuarial values, certain amounts of out-of-pocket expenditures in order to reach the different metal levels, the bronze, silver, gold, and platinum metal levels. And having prescription drug out-of-pocket maximum means that's fixed, means that there may be more medical out-of-pocket exposure, non-prescription drug medical out-of-pocket exposure. So with that background, it directs the Department of Vermont Health and Access in consultation with DFR to consider the feasibility and potential impacts on premiums and plan design of allowing insurers to offer plans in the large group market and at each metal level in the individual and small group markets that do not include the out-of-pocket limits for prescription drugs that are set in statute. There is an overall out-of-pocket maximum under federal law that would not change. Provided the insurer also offers plans in the same markets that do include the out-of-pocket limits for prescription drugs. And by January 15th of 2027, DVHA would provide its findings and recommendations to the committee's jurisdiction, again, including this committee. So again, this is looking at what would happen if there were plans offered both with and without the out-of-pocket prescription drug maximum that is in existing law. Now we have a new section on annual reporting on healthcare sharing plans and arrangements. This would add a new chapter in Title 8, the insurance title, although not health insurance because it's not, on healthcare sharing plans and arrangements. And this would say that a person who is not authorized by the commissioner under the various chapters establishing health insurance companies to offer insurance in this state. So a person not authorized by DFR to offer insurance in this state that offers or intends to offer a plan or arrangement to facilitate payment or reimbursement of healthcare costs for services for Vermont residents, regardless of whether the person is domiciled in this state or another state, must submit to the commissioner of DFR on or before October 1st of this year and on or after March 1st each year thereafter, certain information on the total number of individuals and households that participated in the plan arrangement in Vermont in the previous year, the total number of employer groups that participated in the plan arrangement in the state in the immediately preceding calendar year, specifying the total number of participating individuals in each employer group. If the person offers a plan or arrangement in other states, the total number of participants they have nationally, any contracts the person has entered into with providers in this state to provide healthcare services to plan or arrangement participants, the total amount of fees, dues, or other payments collected by the person in the previous calendar year from individuals, employer groups, or other participants, specifying the percentage retained by the person for administrative expenses, the total dollar amount of requests for reimbursement of healthcare costs or services submitted in this state in the previous year by participants or providers who provided services to participants, the total dollar amount of requests for reimbursement that were submitted and determined to qualify for reimbursement during the previous calendar year, the total dollar amount of payments made to providers in this state in the previous year for services provided to or received by plan participants, total dollar amount of reimbursements made to plan or arrangement participants in this state in the immediately preceding calendar year for services that they received, the total number of requests for reimbursement for services that were denied, expressed as a percentage of total reimbursement requests submitted in the year, and the total number of reimbursement request denials that were appealed, the total dollar amount of healthcare expenses submitted in Vermont by participants or providers in the previous year that qualify for reimbursement under the plan, but as of the end of the calendar year have not been reimbursed, excluding any amounts that must be paid by participants incurring the costs before receiving reimbursement, so sort of a deductible model. The estimated number of plan or arrangement participants the person anticipates in the state in the next calendar year, specifying numbers of individuals, households, employer groups, and employees, a list of other states where they offer a plan or arrangement, a list of any third parties other than a licensed insurance producer that are associated with or assist the person to offer or enroll participants in the state, copies of any training materials provided to the third party, and a detailed accounting of any commissions or fees paid to a third party in the immediate preceding calendar year for marketing, promoting, or enrolling participants in a plan, for operating, managing, or administering the plan. The total number of licensed insurance producers associated with or assisting the person in offering or enrolling participants, total number of participants enrolled through a producer, licensed insurance producer, copies of training materials, and a detailed accounting of commissions or fees. Copies of any consumer-facing and marketing materials used in the state promoting the plan, including plan descriptions, benefit descriptions, and other materials explaining the plan. The name, mailing address, email address, and telephone number of someone serving as a contact for the person in the state. A list of any parent companies, subsidiaries, and other names the person is operated under within the previous 5 calendar years. An organizational chart and list of officers and directors. And a certification by an officer of the person that, to the best of their good faith knowledge and belief, the information is accurate and satisfies the requirements of this section. If a person subject to those requirements fails to submit the required information, that the submission is incomplete, requires the commissioner of DFR to make a determination of completeness within 45 days after the submission is received. If the commissioner is not informed the first person of any deficiencies within 45 days, that submission is considered complete. It gives the commissioner some steps to take if the commissioner determines a person has failed to comply with the requirements of subsection A. They must notify the person that the submission is incomplete and enumerate each deficiency found in the submission and allow 30 days after notice of the incomplete submission to remedy the deficiency. If the person does not remedy the deficiency within 30-day period, the commissioner may impose an administrative penalty not to exceed $5,000 per day. If the person does not remedy the deficiencies within 30 days after the initial administrative penalty is imposed, the commissioner may issue a cease and desist order. And then by April 1st of 2027 and on or before each October 1st thereafter, the commissioner would prepare a written report summarizing the information submitted by persons under subsection A and post the report on its website, along with accurate and evidence-based information about the persons that submitted information, including how consumers may file complaints. It allows DFR to adopt rules as necessary to implement this section. Finally, we have effective dates. The act would take effect on July 1st, 2026, except the expansion of the association health plans would take effect on January 1st, 2028. And section 7, the site control reimbursements for physical therapy, occupational therapy, and athletic training would take effect on October 1st of 2026 and apply to provider contracts entered into, amended, renewed, or otherwise taking effect on or after that date. There's the whole thing.
Deep breath. That's at least 3 bills. Walk through them one at a time. We did, well, it was less extensive. That last section was in a bill maybe 3 years ago. And we decided not to.
Certainly talked about
Yeah,
healthcare sharing plans and arrangements. And you may hear from
in the past,
DFR.
but it was just, yes, specifically about reporting to DFR.
Yeah, it's entirely possible. I don't.
Yeah, no, it was decided not to go forward with that, but, okay. All right, questions for Jen, and this time, I think it may take a while to all settle in.
Yes.
Nolan, you're gonna give us a fiscal note?
Yep.
Okay.
For the record, Nolan Langwell, the fiscal office. 2 things I've really flagged here are the analyses. There's no appropriation for them, but they're worth flagging. I'm going to do them in reverse. I'm going to talk about section 9 first, and then talk about DFR. Section 9 will require DEVA, in consultation with DFR, to consider the feasibility and potential impact on premiums and on plan design of allowing health insurers to offer health insurance plans in the large group market and at each metal level in the individual small group market that do not include out-of-pocket limits for prescription drugs. So according to the Agency of Human Services, if we did a basic no, quote unquote, no bells and whistles approach, the analysis could be done within their current actuarial plan design contract. So DIVA already has contracts with actuaries when they do the plan designs each year for Vermont Health Connect. So adding this little extra in there is really no extra cost if it's basic bells and whistles. So there wouldn't need to be an appropriation for this. However, for them to do that work, because it's actuarial work.
Right.
Section 5, however, required DFR to do an analysis of projected impact on Vermont's health insurance markets, of expanding access to association health plans, et cetera, et cetera. This one is a little bit different, and I'll let Kai talk a little bit more about it, but the way they don't have an actual contract specific to this, the way that they're mostly funded is through bill back. And so the way that it works is, they regulate an entity. When they bill them to regulate that entity, well, there's no one to bill because we're doing a study. So they can't bill back to us. So we would have to give them an appropriation. And there's no appropriation in the bill. And if I'm wrong, Kai will correct me on that. An actuarial study can run anywhere from $15,000 to $50,000, depending on the level. So it's one of those things where if you want to move forward with this and you want DFR to do that work, and this is not your purview, but I think there needs to be some acknowledgement of an appropriation of some sort. I'll let Kai talk more detail about what they would or wouldn't need, but this is really more of a flag of like the bill moves forward and you really want this work done. There needs to be a little thought. So again, I'll let Kai elaborate. He may say no one's wrong. We could do it within our budget. We're glad to do it. I don't know.
This would do a study of taking out any out-of-pocket payments for pharmaceuticals
It would.
on the exchange, which I assume would add cost to.
Yes.
So it's another grain of sand on that. So it beach.
I'll let Jen.
Yeah, it would allow for more flexibility in plan design. So there might be plans. I don't know that it would per se.
Oh, okay, so there would be a plan in which there was no out of pocket.
So there is a federal maximum out of pocket that applies to all plans.
Okay.
And then under Vermont law, because we have a prescription drug out of pocket maximum, the rest of that space can be, depending on the plan design, up to that full amount can be the medical out of pocket maximum. So this would allow the insurers to design plans that maybe had some plans that had a higher prescription drug maximum out of pocket, lower medical expense out of pocket. That is different from what is available now. There's thought that some policyholders might prefer a different design, but I don't know.
Take a lot of drugs. That's
Right, somebody has, it's right,
I
somebody
take
takes higher
high cost drugs.
Right.
That's
And there's
okay.
concern about also getting rid of that maximum for people who is a significant benefit too. So,
Okay.
This would be trying to understand that impact
exactly. trying to
Okay.
understand that.
versus just doing
Okay, would be a good thing to do. Question
it's
is,
informed decision.
how much of a good thing when we get the bill? All right. Okay. Other questions for Noah? That's all
Easy peasy. I like it.
in all of this?
Well,
I don't know what we've got in there.
you get it because it's insurance and there's a penalty.
Okay, we're gonna move on. We're actually 5 minutes ahead here. Kai Sampson. And is Mary, you and Mary a tag team? Are you separate?
We're gonna go sequential today.
Sequential?
Yes.
Okay.
So I'm gonna cover sections 1 and 2, the governance, public health insurer governance, compensation, and pass it off to Mary. And I think Mary will be passing it off to Joe. Quick note on the fiscal note. regarding the study of the, in 585, I guess it's section 5, around the sensitivity to the risk pool, the impact on the risk pool, the small group and individual risk pool of AHP expansion. That yes, we do primarily bill back our actuarial contracts. I believe the scope of how that's written in the study, that we can absorb that through existing contracts that aren't reimbursed. So we do have similar to what you heard on vehicle, we have existing budget that can be absorbed, and worked with the House Committee to scope out the language of that study to be, I think, useful beyond just issues of how would increased association health plans options impact the small group. Primarily what you see that language, what we want to look at is, in a group, we use the term morbidity or the health of that pool, which for community rater impacts everyone in that pool. What it's very difficult to estimate behaviorally without knowing every single profile of every single small group in the state that's in ERISA or in the level funded plan, or using ICHRA where they put their individuals into the individual market, or just don't offer at all. So without knowing that, which is, I don't say impossible, but practically impossible to figure that out. And then what price sensitivity would they move, et cetera. What I discussed with the chair over in House Healthcare was what we can do fairly simply. And there's more than that in the study, but the primary goal, as I see it, is let's understand if the top 1, 3, 5, 10% healthiest, the healthiest top 1, 3, 5%, choose some numbers of each of those pools leaves. All of the things being equal, what's the impact on the morbidity of the pool remaining? What's the price impact of that? That's just great information for all of us to know. So I think that analysis can be fairly straightforward, not problematic for everyone. So much more nuanced answer, but that's where we stand there. So I don't see myself in a position to ask for budget for that. So then jumping into section 1 and 2 of 585, this was language that came out of DFR and originally, and it looks at nonprofit hospital medical service providers, of which that's chapter 123 and 125 of our statute, or perhaps just one of the two. I may stand corrected. Oh, and do we have Russ McDonald online?
Yes.
Okay, thank you. So Russ is an attorney in department who can help with any of the legal
Okay,
or questions.
on the witness list.
He's in the meeting on
He's in on Zoom, okay. Because we have him scheduled after he's married, but I gather he's
Oh,
just
okay.
there to
Yeah, and I think
be your.
mostly to
Okay.
support on this one, because there may be questions, but so at this point in time, we just have one company that is enabled by statute as a nonprofit medical service provider. Sorry, I was mixing up medical or hospital. They may be both. Russ can jump in, but so this is aimed at those entities, of which currently there's just one, which is Blue Cross Blue Shield of Vermont. I believe strongly in my years of regulating that governance and power at the top is one of the most important things for a well-managed and run company. This proposal is not radical, in my opinion. There's a board of directors of 12 members at Blue Cross Blue Shield of Vermont. This proposal says that 2 of those 12, but if they expand the size of the board, at no time is it less than 1/6 of the board shall be made up of governor appointees. Why do I feel that's necessary? I think this committee and several other committees, if not most of the legislature in the state of Vermont, understands that we had some issues, solvency issues with this entity. We've had a lot of very strong, good management decisions made by this entity, as governed by the board of directors. But there's also been questions about strategy and direction that may have contributed to some of their financial challenges. The board as it stands now is what I would call a self-perpetuating board, not unlike many nonprofit boards, not unlike many mutual insurer boards. And I believe, department believes that having, we could rewind the tape, having had some greater state of Vermont wide, public policy wide influence, not control, influence on the board, could have changed, could prevent the next issue in terms of managing the political environment, in terms of managing the regulatory environment, but also, as you'll see explicitly written in the proposal, laying out that these two appointed board members, unlike the other board members of the entity, have an expanded duty to fulfill the healthcare transformation requirements referenced in statute that the legislature has adopted, and to have that lens and also the lens of all of the state of Vermont. So really, in a small step, doing in the direction of formalizing a statewide approach with by far our largest health insurer in the state. And currently the board has a focus on subscriber development. So these two members appointed by the governor would have a charge. Some of that language is brought from B Corp statute, which I'm sure many or all of you are familiar in terms of what their charge is, in terms of the influence they are to have on that board.
I think it would be helpful, I'm not sure who can do it, but to see who appoints which board members. I will say I'm a little leery about, we may all love our present governor, but we may not love the next governor as much. And I'm a little leery about putting political influence into what should be a soundly run financial organization. So I want to look at the qualifications for everyone on that board to make sure that they have the background necessary to make the complex. If I felt comfortable with that, then I probably wouldn't mind two political hacks at the worst.
Right.
But
So for
I
these,
want to make sure that we are sure that there's enough people that understand running an insurance company and what is required and what the financials should look like, as opposed to what somebody's constituents want them to look like.
yeah, no, and as their chief regulator, I agree with everything you said. And I
We
think
have to
maybe,
find out how to write that.
right, maybe Russ could go through the current structure of how that company, the parameters with which they operate.
And
their board.
we could do that another time, but
Okay, we'll do that another time. Okay. Very briefly, they have 12 board members currently. They have a nominating committee. They have a controlling, they are a controlled affiliate of the Michigan Blue Cross Blue Shield. And that controlled affiliate does have oversight and over the board. But still in their bylaws, there are 7 locally nominated appointed members to the board, and then 5 explicitly nominated or placed there by the parent, Michigan. So there's still, so there's a 7-5 split at this point, and this position would say 2 of those would be these appointed.
So replacing 2, not adding 2 to go to 14.
very technically, it says you need to amend your bylaws to comply with the statute. They can do that in any number of ways. Expand the board. That's why it says 2 or no less than 1/6. So if they wanted to add 2, they'd actually have to add 3, I think, mathematically. Yeah.
Okay. Second one.
Is there anything there about compensation levels for board members?
Not in our
I didn't see anything.
No, and I will, it's thanks for bringing that up. An important feature of this is that these 2 appointed board members, and it's written in there, you explicitly need to follow all the code of conduct and rules that any board member has. So to help protect against the concern that
Yes.
they are political hacks, as you put it, that are spouting off and giving confidential information, anti-competitive stuff, whatever.
This is a painful.
It is a paid board, yes.
Where is the compensation level
Currently,
written?
that would probably be in the bylaws. Or,
I don't know.
I'm
I
not-
tried to look it up and I wasn't able to find anything.
Oh, it's in the Mary help me, the Act 153 reports, or the reports that come to us with the Care Board compensation. It's also on the annual supplemental compensation exhibit, which lists the top earners at the company, all our insurance companies, domestics, as well as board of director pay. But it's certainly not prescribed or directly governed by DFR, any insurers board compensation, but they are compensated positions, and this doesn't change that for these 2 or for any board members. And then the remainder of the governance section, as I call it, gets into the compensation decisions, and not unlike most companies of this size, insurance or not, the board has a process and a committee to determine executive level compensation. And a very common practice is to hire an outside consultant to benchmark and at times provide recommendations for both base salary and bonuses and other forms of compensation. Those benchmarks, I think, can either drive the compensation decisions or give comfort to the board and compensation trajectory that they have for the executive leaders. What was concerning to me, I've been on the job for about a year now, is that I inquired of that data of the consultant, and the consultant used, I'll use general terms here, another data source for benchmarking, and all they could produce was the actual benchmarks for the folks that Blue Cross was looking for compensation advice on, but not the actual underlying data. So I was curious about was which companies are in your market study? Are we comparing these pay packages to nonprofit food co-ops in Vermont, or are we comparing them to multinational reinsurers? Neither of those, I hope, are in the pool, but I need to make sure. And that data wasn't readily available. And I will say there was a commitment by management to ensure that in future, compensation studies, et cetera, that they would have that available. I'd like to put it in statute that that's an expectation for this type of company, that the regulator can see the peer group that's being used. And furthermore, we can, as you'll see in the language, we can add to that peer group. We can add, and it doesn't even have to do anything with that. It doesn't compel them to say, oh, you put the food co-op in the peer group, so benchmark just changed. You have to react to that, but it does allow DFR to have some influence and oversight of peer group in the company.
Thank you, Madam Chair. I appreciate that, the peer group and compensation. I'm curious, is it common to have the regulator say we want to make sure that we have 2 seats on your board? essentially? Because I know it's not directly you
Right.
saying it, but your boss would be appointing.
Right.
So it's essentially it's the regulator appointing two members of the board. Is that a common structure?
I would disagree that that essentially the regulator will be appointing two members because I explicitly said that it would be inappropriate for me to do it, right? So so that would be inappropriate in terms of governmental appointees to a board like this. That is uncommon. It's been attempted in other states. It may have at one point been the case in another state. Russ, chime in if you have any of that history. But what I'll also say is that there are only two that I know of, two single state nonprofit Blue Cross in the entire country. Vermont is a very unique market, as I'm sure you all know, in terms of health insurance and consequences of success or failure of a nonprofit carrier. And history of solvency challenges is also extremely uncommon. So I think it's a confluence of those factors that drives me to recommend this or that we have proposed this.
No, I mean, I agree with you that the sort of gravity of the situation calls for, I'm just curious about, it sounds like it would be a unique structure to have the governor appoint. Okay. And if the goal of it is to have sort of some internal oversight, is two members going to be sufficient?
I believe it will help. I don't know. I think it's a big deal, right? To add that type of intervention into a board and
to direct them to change their bylaws too. Oh, is that
we have some regulatory authority over the bylaws already.
okay?
I mean, the level of direct and then kind of both that authority we have for our domestic insurers is pretty big. And this is not as big as saying we could just appoint without legislation board members, but in terms of bylaws and other things, we have quite a bit of influence. There's certain things that are significant enough that definitely need the legislature to take action. In terms of is it enough? To me, I think it's an appropriate step to just influence and bring some outside perspective onto that board, given how kind of important and inseparable that company is from our healthcare policy and trajectory in the state, and the consequence that we got dangerously close to losing them as a payer.
So sorry, Benny, the changing the bylaws that you do in other contexts for other different types of.
Not changing them. I believe we can review and approve them. Russ, do you know offhand, or Mary?
We do review and approve.
Yeah.
In
Bylaw
other
changes
different types of insurance companies
for
or
all our domestic insurers.
okay. I'm most familiar strangely with the captive insurance because I come in here every year and we talk about it. So I understand that sort of level of regulation, but I was just wondering for other insurance companies,
Right.
what is this in the norm or outside the norm? So
Yeah, and it reminds me to touch on that. I know there's a concern from the nonprofit community that this is a slippery slope, that, government's now going to intervene in all nonprofits. And I thoroughly reject that idea. This is a very focused, statutorily prescribed placement of board members in very unique situations we just talked about. Any other scope creep or slippery slope would require equally controversial legislative language, right? I mean,
yeah, I wonder if I know we're not to mark up, but just putting a pin in this, but wondering if we might want to include language. I don't think it's in here yet. That sort of gets to that point of why this is a unique situation and sort of helps allay the fears.
Findings.
Maybe, well, I mean, more intense language maybe because findings go away. I don't know, something that might help people feel more comfortable. And this is why we think this is the appropriate level of oversight. And also maybe creating some kind of barrier between you, the regulator, and the appoint, like you wouldn't have a role in it. And yeah, just thinking as.
Yeah. And along those lines, that discussion of governor appointees, legislative appoint, that was discussed quite a bit in House Healthcare. One model that I looked at and have no objection to is how we appoint Medicare board members, which is very legislative driven to the governor and then governor selected. And, you know, from our analysis, does not take a tremendous amount of editing of that statute to just include, because the principles are the same. The references to healthcare reform and priorities are the same in my mind, in terms of the type of person we want.
Right, and it puts some qualifications on
Yes.
people
Yeah,
too. This
exactly.
is style to the qualifications, yeah.
Ultimately, I think simplicity one day.
Yeah, that's fair. Okay.
And I guess if there are no further questions.
So, these two board members, would they have the same fiduciary responsibility as the other heads?
That's gotta be a Russ question. I believe the answer is no, because they have a separate duty described in the section.
Okay, and my second question is, do they have the same confidentiality agreements as the other 10 board members?
Yes, they will have to comply with everything that an ordinary board member does, which.
So,
Apologies.
No, go ahead.
I'm happy to jump in on the first question if that's helpful. These two board members have different fiduciary duties, and they are the duties that are spelled out in the markup section that I just had and scrolled away from. In section, it looks like E1. This is so says in determining what the representatives of the public reasonably believe to be in the best interest of the hospital service corporation, they can consider the effects of action or inaction on the items listed below. So subscribers, community and societal considerations of the state, including the Act 48 principles, and the goal that the hospital service corporation's benefits and services should be provided at a minimum cost under efficient and economic management. Particularly in that list, item B is, I think, different than what would typically be understood as the fiduciary duties of a director.
so who would if you're one of the 10, your fiduciary responsibility is Blue Cross Blue Shield. If you're one of the other two, who is your fiduciary responsibility to?
Well, I think it's still to Blue Cross Blue Shield of Vermont. It's just the duty itself is understood slightly differently.
And you said that they have the same confidentiality agreement. So would that preclude them from communicating with the appointing authority, the governor? Or are they like moles?
No, fair question. They need to behave like any other board member.
Okay.
I mean, if the chair of the board would take action against a board member who, without any knowledge or any discussion, went with the governor or the regulator to share information, if that's a breach of current board rules, then that's no bueno for this appointee.
Okay. Thank you.
I love how chill you asked that. Are they?
We can spend some time on this one. The chair likes charts, so I presume we can't get a chart as to who the board members are, who a subscriber is, and then who represents subscribers, who's a make sure we've got a balance and to make sure in there somewhere somebody has enough financial understanding and knowledge to know what's being talked about, and to understand the impacts on their own without having to take the word of somebody else. Okay. All right.
So the next section, Deputy Mayor Block is going to cover.
Okay.
Thank you for your time.
Thank you. Sure, we'll hear from us again. We're just trying to keep you awake by going back to work.
So for the record, I'm Mary Block, I'm the Deputy Commissioner of Insurance, in the Department of Financial Regulation, and I'm going to talk about association health plans. So this is section, starts in section 3. So association health plans are exactly what they are group insurance plans that consist of an association group of employers who are connected in some way generally. The most common one, I mean, very few in Vermont right now, but we do have one big one, which is the Vermont Auto Dealers Association has an association health plan. So it is all of the auto dealers in Vermont. They gather together so that they can get an insurance plan that covers all of those members. In doing that, it allows them to leverage their size. They are a large group plan, association health plan, because they have a lot of members, as opposed to a small employer on their own who would either small group market or try and go self-insured and so forth.
Before association plans went away under federal law, it was the Chamber of Commerce who was the biggest provider. And if not almost all pretty close small businesses in Vermont joined the Chamber of Commerce and were thus able to form a large group, take advantage of that large group. And when associations went away,
They were all on their own.
they were all on their own and they were hurt.
So the way the law currently stands, the federal law is limited at the moment. Trump 1 administration broadened association health plans. The Biden administration narrowed it back down again. Vermont's definitions are even narrower than the federal government's. And there are two pieces to this. There is a statute, which is what we're talking about, and then there is a regulation that goes with that statute. That regulation defines the benefits that those association health plans have to put into their plans. So this would be a two-part process. We would change the statute so that it would trigger off of federal law, so that if there is a change in the federal law that broadens it again, then we would automatically have broadened that ability. And then we would also have to change the regulation, because right now, the way our regulation reads is we force association health plans to maintain the same standards as the individual market. So they have to meet all of the exact same mandates and everything else as the individual small group market. Traditionally, association health plans, because they are larger, are allowed to meet the standards of the large group market, which provides them more flexibility around benefit design. So we would change the regulation so that when broadened, they would also be able to be treated as a large group again and have that large group benefit flexibility. Those benefits and those plans still have to be, the rates still have to be approved by the Vermont Care Board. They still have to be filed and approved by us. It would increase the size of eligible employers who might be able to take advantage of this structure. So when we originally proposed this, we proposed making change for 2027. The House Healthcare Committee was a little uncomfortable with what the effect was going to be on the markets, the small and the individual group market. So they asked us, they put the language in that would require us to do the modeling that Commissioner Sampson talked about and postpone the effective date until January of 2028. So we will do that study, figure out to the best we can, because it's hard to tell who's going to choose to join the
association and who's not. And do some modeling as to what the potential impacts are if, we decide to do that expansion. We feel like it provides an option to employers that they don't have right now. It may adversely impact the small group market. So it's a balance. People are, and employers are desperate. Some are choosing not to provide health benefits at all at this point. This might give them the option to do so again if they had a palatable plan that they could get into. So we feel like providing options, is something that's just doing at this point.
Probably. So I've been through all of these iterations. This is probably one of the most painful discussions this committee has. Because it's really who's gonna bear the pain.
Yep.
If we help out the small employers by letting them associate and join the large group market, they're gonna benefit. But we take that lower morbidity group out of the individual market. We're just frequent people who are not employed, whose employer doesn't offer insurance. And these are often people with some chronic illnesses. They get hurt.
Yes.
And with changes on the exchange, you know, people across the board are hurting, at least in that small group individual market. And if we take out healthier people, they're gonna hurt more unless we can find something else. So
Yeah. It is concerning. We are hearing from the federal government. It's nothing official at this point. We did have a meeting with CMS, the Center for Medicaid, recently, that an expansion is probably on the horizon. We also got a very clear message from them that they have no intention of really supporting the small group market. They are pushing more towards the use of ICHRAs, and the individual market, which means employers contribute certain amounts and then employees go buy on the individual market. So we're not probably going to get help from the feds. From the feds, they're looking to shift the dynamic here. So we will either be trying to hold firm the wall or attempt to go with the shift and make the best of it.
now we can go back to having 7, 8, 10% of our population uninsured. Which leads to higher morbidity and higher costs because they do show up in the hospital.
Yes, there is no simple answer.
Okay,
I remember this conversation in 2021, when we did this the last time.
Yes,
And
yeah, well. We went through this with single payer and. It's actually modeled on the Taiwan system. So Taiwan did really well during COVID. So, yeah, okay.
questions? Or should I pass it off to somebody else who's got cheerier things to talk about?
With anything cheerier today?
But at least simpler.
this is just putting into place, if the shift in the federal government, this would make our statutes
Shift with it.
shift with it.
Yes. We would still have to take the second step of changing the regulation. And then once the shift happened at the federal level, the regulation would be changed and they would get the full benefit of an AHP.
Just say everybody's in one market? That wouldn't work.
No, unfortunately, we always struggle with the fact that in reality, we only influence about 30% of the market, 20% of the market. Right? So there's another 70% that's in the original market that's
You
doing
can cover
all
hearing
kinds of
aids
things,
or not cover hearing
right?
aids. They
Self-insured,
cover,
stop loss.
yeah, they can do
Yeah.
whatever they want. It is a private agreement between you and your employer. And,
We don't have any influence.
and we don't have any. Oh, dear. Okay.
All right, I'm gonna pass around to Joe for a couple of things.
Well, at least it's not Friday. Going forward.
My mother said Friday.
It's Monday.
Yeah, it is, we're just starting out, all right,
All right,
Joe.
for the record, Joe Valenti, Director of Policy at DFR. I am going to cover sections 6 through 8 and then hand it back to Mary to close us out on the bill. I think these are both fairly straightforward. So section 6, as Jen had pointed out, is dealing with prepayment claims edits. So there was language in Act 111 in 2024 that restricted the use of prepayment claims edits and provided some exceptions to that. One of those exceptions was the case of high dollar claims. Now, high dollar claims was never defined. And so there was some uncertainty about when a claim would be sufficiently large to be exempt from prohibition. We spoke with insurers, and I believe one of them was already using the threshold of $25,000, but they found that to be an adequate threshold. So all we're doing in section 6 is replacing high dollar with claims exceeding $25,000 per episode of care. Now, this is not a requirement that any claims above that level need to be subject to prepayment validation. It is an option for the insurer that they have the ability to do that. It also doesn't limit them to a $25,000 minimum. The existing statute does have other exemptions for fraud, waste, or abuse, or other circumstances. It just provides more clarity around when a claim can be subject to the prepayment validation review.
Okay, and this is back to Bill that did away in many cases with prior auth
Yes.
Yes.
and we did away with or changed the
Change.
editing.
Mhm.
Then we had one insurer say, if I have to change my whole editing system, you're such a small part, I'd be out of here. So the next year, I believe, adjusted the editing, you adjusted,
We adjusted prior authorization.
you adjusted prior auth, okay. So this is going back and in that bill, and some of us tried to amend that bill in a bipartisan manner and failed. I was looking for an actuarial assessment before we did it. But so this construed to prohibit target prepayment coding. Can you tell us what that means in English?
So there is a definition in Act 111 that I brought with me.
It's on in paragraph E1.
Yes. So this is prepayment coding validation edit review. That's a mouthful. Means any action by the health plan, contracting entity, covered entity or payer, or by a contractor, assignee agent, et cetera, requiring a healthcare provider to provide medical record documentation in conjunction with or after submission of a claim for payment for health services delivered, but before the claim has been adjudicated. So they haven't, my understanding here is they have, they've received a claim, they have not paid it yet, hence prepayment claims edit, and they are looking for additional medical record documentation to be able to evaluate that claim.
Okay, so they want to know that it was medically sound and that it was actually delivered. All right. And then I assume all those costs would also be covered by all the work that's being done on hospital charges in the community down the hall.
Just a question,
Okay,
and that is in terms of the review of the kinds of claims referred to here. Is there any thing regarding the time that such might take, or is there any limitation by saying that a reasonable period of time or otherwise? Because I couldn't find anything that defined what this additional review might consist of.
That would depend on what's in Act 111. I'm not positive
The-
that there is
So
any.
there are a lot of timelines dependent upon the individual situation. And most of those timelines are built to not impact the consumer. So sometimes, for example, a claim will get denied by the insurer back to the provider, but the claim being not to the insured. So everything is geared so that nobody comes after the insured for that payment until the insurer and the provider have sorted out what's the right payment. But timelines depend on, for example, there are short timelines for prior authorization. There are certain timelines for how long a claim needs to get adjudicated, for when a provider can object to an adjudication. All of those are in statute, and there's a variety of timelines depending on.
Well, in other words, what I'm
scenario.
really looking for is from a consumer standpoint. Can a consumer get caught in the middle of this between the dispute between the regulator and Blue Cross as to whether or not something should be paid? And then what's the recourse from the consumer's perspective?
So the consumer shouldn't get caught because anything, for example, oftentimes the insurer will reject an extra billing code on a claim.
Mhm.
That rejection goes to the provider, not to the insurer. So the insurer, as far as they know, their bill has been paid. And there's a fight going on in the background between the insurer, and the provider, but it is not getting billed to the consumer at that point. It doesn't affect them. Okay. Other questions?
And then sections 7 and 8 are dealing with site neutral billing. And this is narrowed down significantly from what was initially proposed in H585. Site neutral billing is a concept that it's an emerging practice. Medicare has been working on this for various services over the past decade or so. The idea is that if you have a given service that can be delivered inside a hospital or outside of a hospital, there shouldn't be a price differential based on where it's delivered. If you think of something like, we're not dealing with doctor visits here, I'm just using this as an example, but if you were just conducting an office visit with a physician, no special equipment involved, and you are having that office visit at a hospital or in the community, there shouldn't be two separate rates for that. There's no reason for that service to take place in a hospital at a higher rate. And in Vermont, there are a lot of services delivered in hospitals compared to other parts of the country. But it is frequently seen, particularly in other places, that things like, again, like doctor visits, lab work, x-rays, MRIs, don't necessarily need to take place in hospitals. When they do take place in hospitals, they may be taking place at a higher rate. And so we had started this process with a bolder proposal to look at site neutral billing for a list of services to be determined by DFR and the Green Mountain Care Board. That was going to be complicated. It could be potentially risky to hospitals because of the volume of services that could be implicated there. And so House Healthcare decided to take a narrower approach to pick one service where the cost differentials were known and where we could sort of try this out. And this was the area of physical therapy, occupational therapy, and athletic training. And I believe the testimony for that had identified what the specific codes would be. Part of the expansion from PT to include the other two categories just dealt with the sort of interchangeability of the services, and that it would be easier to cast a wider net and make sure that you weren't inadvertently sort of favoring one over the other. So if you, to give an example here, if you had a physical therapy service and the rate that the insurer would pay inside a hospital were $300 and outside of a hospital were $100. This bill would say that instead, if it is truly an outpatient service, it doesn't require the higher levels of care of an inpatient service, that each insurer would set one rate for that given physical therapy service that could be, it's probably not going to be 100 or 300. It's probably going to be somewhere in the middle. It could be 150, 200, 250. That would be a negotiation, but that rate would apply to all outpatient physical therapy services using that code in the entire state.
I just have a question. Because I had a constituent who got caught in this getting physical therapy, went through her insurance, had a stroke, was really improving, figured I could do it at $90 a session for X sessions. Couple months later, she gets a $30,000 bill from the hospital. The hospital had taken over the physical therapy office. Around here, that's more common than not. As I understand it, by the note that was taped to my provider's desk, there's a fee and then there's a $200, it may have gone up now, facilities fee, because you have the benefit of all the knowledge in the teaching hospital. Is what the insurance company is going to pay inclusive of that $200 fee or exclusive? Are they going to all get 100 plus the one that is part of the hospital is going to get in the end 300?
So my understanding, and I will defer to Mary or Kai if I'm missing something here. We are not tackling the practice of facility fees here at all. I know that there have been bills introduced to deal with facility fees as a separate component. But as we see, this is the
fee.
Right. This is the rate for the service that is delivered and standardizing that across all settings.
Think from what I've heard from the physical therapist, we had them in health and welfare last week, the week before. They are having a very difficult time as private practices surviving. So it's mostly the reimbursement.
Thank you. There's nothing in here that says that the fees should be the lower of the two fees. They could just reimburse them all the 300 instead of all the 100 in your example. And that would just raise healthcare costs across the board. So it seems to me that we would want to include something that, the goal of this is to save patients money.
So we expect that it is going to be a negotiation. We expect that it will fall somewhere in the middle. Per various conversations, ideally, this is a way to cut costs. It may, in the short run, it may just be sort of neutral, but it's spreading that around between the hospitals and the independent providers who, as you noted, are struggling with the rates that they have. There's a certain competition angle here that if the rates are brought up from the 100, it may be easier for the independent providers and also to encourage new market entrants for this or any other service that could increase competition. I think with regard to, so I don't expect it to naturally gravitate to the highest level. The initial proposal that we had involved identifying services and the Green Mountain Care Board setting rates for those services. And I think from talking to House Healthcare, there were issues about resource constraints. I think there were also concerns that it could be too heavy-handed of an approach. And I know that there's a debate going on around reference-based pricing and exactly where you set those targets. So rather than having a government body set what those levels are, we decided to subject it to the normal negotiation process for insurers, just that whatever rate they set in Vermont for a given outpatient PT service, that rate would be uniform no matter where it was.
Across the state?
Yes.
Okay.
Now, one of the things that we had considered, but did not include, when we were working on the original version, was whether there might need to be some type of a carve out as there was in Act 55, if there were scenarios where critical access hospitals would not be able to meet that change. If you think of a world where you have hospital providers and independent providers and it's fairly competitive, site neutral encourages that competition. That can work pretty well. It is true if you are looking at a service where it simply is not happening outside of a hospital, right? It's less competitive, then someone could look at site neutral as really as being a, just a cut in the level of payments that are.
Okay, I think I know why Health and Welfare wants to look at this. Bill. Okay,
Anything else on site neutral? I will pass it back to Deputy Commissioner Block for the last handful of sections.
okay.
Okay,
It's like musical chairs.
it is. We're keeping you away.
Getting our steps in.
All right, so the last two sections were not in the original version of our bill 585. These were both added by House Healthcare at Chair Black.
This is the third bill.
Yes, this is Chair Black's additions to H 585. So I will start with the out-of-pocket max. She originally added language to eliminate the prescription drug out-of-pocket max mandate that's currently in state statute. After much discussion and questions about the impact of that, the language became the study that Nolan talked about, that Eagle will do as a part of their actuarial work, looking at the plan and that we will assist them with. So we'll take a look at what potentially the impact of removing the prescription drug out-of-pocket max is. I believe we'll probably look at some scenarios of, do we have some plans that have no out-of-pocket max? Do we have some plans that do? Do we, change the total out-of-pocket maximum versus the prescription drug and so forth, and see what those variations might be. But that study will inform whether next year it makes sense to take out the prescription drug out-of-pocket max and see where we go from there. Finally, is the reporting on healthcare sharing plans. This was actually H102 originally.
Yeah.
Which I think was introduced last session, but there was a prior version
Version that did not come out here for a reason.
So Chair Black wanted it inserted, so she has added it to the bill. It is a reporting requirement only. DFR would receive the information, we would digest it, we would create a report, and we would post it to our website. It would provide information to us about sort of what the alternative healthcare reimbursement mechanisms are operating in the state. It would provide information to Vermonters about what those alternatives are as well. But other than that, we would do no regulation. We would merely take information, digest it, and put it back out.
The reason it didn't come out of here was the fact that we've already said in law, they are not health insurance.
They are not.
Your health insurance people can't sell them. They can't call them health insurance. They are not health insurance. There was a concern that if they had to report everything to the Department of Financial Regulation, they could say we are overseen by, or we report to the department, which would give them maybe in the public's eye, more legitimacy than some people were comfortable giving them. So that's, but I can also see it would be helpful to know. Because we have had at least one large, of these groups go under. And there were people that were hurt. There probably have been more.
There have been more in other states,
Yeah,
not here.
no,
We did have one where we issued an order, cease and desist order. Because they were crossing the line and it appeared that they were selling insurance because based on the marketing materials. And we do get periodic inquiries from consumers asking about, you know, what is this? You know, I thought this was gonna cover this
Yeah.
or that and so forth. And so we do have those conversations. But there are others that are operating and have been operating for a long time that we hear nothing about. So they are just an alternative.
religiously affiliated.
I would say the majority of them are. There are some that have developed that are not necessarily religious at this point. They have similar requirements. There are some tenets of the organization that members are required to follow, but they are not necessarily all religious at this point. This is based on a Colorado law that was passed in Colorado and is operational. It has been challenged constitutionally. So they have been sued. It has not finished making its way through the courts. The Healthcare Sharing Ministries lost on a preliminary injunction that they attempted to get, but it is still making its way through the courts, so.
Okay. We can, I know their representatives are here. They left when we needed space. But they were very clear with me today. We weren't taking testimony. I might very well have 237 out of here, hopefully in a few minutes. Hopefully. I guess how the ones are beating us with the first bill out on Jane.
No, we got beat by judiciary.
We got beat by judiciary. Well, maybe we can come in as number 3.
All right. Any other questions for me? I think that's the end of this really long bill.
So. Yes. And again, we may not want to do this because we have in the past, if there is an active lawsuit. Lawsuits are expensive.
Yep.
So we'll let Colorado pay for it. And
Certainly you're on.
yeah. Okay, because there is no mandate that anyone has health insurance. So you can choose not to, or you can choose. The question is, how are they presenting themselves? Do people understand the risk?
Yes, if they present themselves as insurance, then they fall under our jurisdiction. Yeah, we would be able to take action.
Right.
But if they present themselves appropriately, then they don't fall under our jurisdiction.
Okay. Thank you. Thank you. We've been through our initial walkthrough.
Time when these photos happening.
Would you like to take about a 10-minute break and then come back? I think we could get 237 out of here.